Okay, welcome everyone. I'm going to briefly pin my video. There we go. Hello everyone, welcome to our second Zoom public event at the Hagop Kevorkian Center for Near Eastern Studies at NYU. Today we have a fantastic pair of guests to discuss the responses to the coronavirus pandemic in the Middle East. Before we get started, just a couple of housekeeping notes. We will ask that everyone in the audience remains muted. I'll also point out that this is our second event. We had a fantastic event a few weeks ago on history of epidemics and quarantines in the Middle East. And if you missed that, it is available on our YouTube page. And I'll ask Fidel maybe to post the link to that in our chat. So if you want to check that out later, you can. And I do also encourage people to seek out other events at our partner centers at NYU relating to the coronavirus pandemic. Our friends at the Center for Latin American and Caribbean Studies are hosting a series on food security and the coronavirus pandemic, which I think continues this Friday. We'll try and get a link to that to everyone in the chat as well, if possible. Okay, so without any more business, I want to get things started here. We are very, very pleased to welcome Amira Roess here today to speak about various aspects of the response to the pandemic in the Middle East. We'll have a presentation from Amira Roess, who is an epidemiologist, and we'll speak about more broadly the that's a tough word, epidemiological aspects and responses, in terms of public health from other parts of the Middle East. So Dr. Amira Roess is a professor of global health and epidemiology at George Mason University in the College of Health and Human Services, and also in the Department of Global and Community Health. She's an epidemiologist with expertise in infectious diseases, multidisciplinary and multi-species field research, and evaluating interventions to reduce the transmission and impact of the infectious diseases. Dr. Roess holds a PhD in global disease epidemiology and control from Johns Hopkins University. And prior to joining academia, Dr. Roess served as the science director for the Pew Commission on Industrial Food and Animal Production at Johns Hopkins, and was an epidemic intelligence service officer at the Center for Disease Control. So we're really, we're stocked to the gills with expertise here, and I'm really, really eager to pass these things on. Please join me in welcoming Amira Roess.
Thank you for having me and for hosting it. What I'm going to do is really briefly talk about the basics of public health surveillance and public health response with some key experiences from the Middle East in general. And then I'll talk about key populations and some challenges that we face in MENA, followed by some of the global and regional efforts that had mixed results, and some things that need to really strengthen, especially considering that if you look at the last 50 years, the number of pandemics or public health emergencies of international concerns have really increased. It's no longer a 100-year event. Instead, we're seeing these, relatively large pandemics emerging, with this one being the largest, maybe every 10 years or so. And so the global and the regional partnerships really have to be fortified, and the surveillance systems that we establish right now globally have to really be supported for the long haul. So the basics of public health response, really we're going to think about the health system, and the WHO defines a health system, and they have set what they call building blocks. One of the critical parts of the health system is really the surveillance system, and that will really rely on reporting, and reporting relies on identification of new novel cases, and that needs to happen well. And you need to have a system that allows healthcare providers, whether they're physicians or nurses or others, to be able to report somewhere. And surveillance really should be unbiased, and you shouldn't have these worries of having information squelched for some, political or other reason. Testing is a really critical piece of surveillance, and again, you need to have an infrastructure to support testing, as well as symptom tracking. So in a novel outbreak like this one, when you don't have tests available yet, you do need to track symptoms and you need to track exposures, because as we've learned, asymptomatic infections, that is infections when the person doesn't have any symptoms, are really important to identify early on in order to reduce transmission. And this is where a lot of our systems globally, in Iran included, as you heard, where our symptoms really failed. We didn't know that this was a novel virus circulating. In many parts of the Middle East, cases were probably circulating a month before the world realized this was a new virus circulating. And so the basics of public health infrastructure and health systems are really critical, and we have to think about building these up for the long haul. Following testing and identification of individuals with exposures and symptoms, you then really need to implement contact tracing to identify, who's come into contact with whom and who might need to stay home and really limit their interaction with other individuals. Some of the interventions that we have seen coming as a result of this contact tracing activity included stay-at-home orders and wide-scale quarantines, closing the economy. And, this has been very difficult for many countries and sub-districts to implement, because it comes with a big economic cost, and in a way it really flies in the face of some of the cultural norms. If you want to go to a place of worship and you're used to going there, you're going to want to keep doing that. And it's difficult for governments the world over, to really make the decision to quarantine or close economies and then to enforce them. It's very difficult to also enforce those. There's also some real issues with the healthcare infrastructure that have kind of highlighted our vulnerabilities. So for example, we've learned that this coronavirus, along with many other respiratory pathogens, they spread rapidly once a patient is in a healthcare system. And so, before COVID, many countries in the region were struggling with outbreaks, iatrogenic transmission of hepatitis C, HIV, other bloodborne pathogens. And, in the case of MERS coronavirus, which affected the Gulf pretty heavily, we did see very large outbreaks linked to hospital settings, and patients that were being treated in the hospital for MERS coronavirus ended up seeing outbreaks in the hospital system linked to really poor infection control practices. So these are some of the key things in the healthcare system that we think about. Now, the case of MERS coronavirus did end up inadvertently, really improving response in some of the countries in the Gulf. Because of MERS, you've seen some countries implement very good infection control practices in the last 3 or 4 years. You've seen an increase in negative pressure rooms in the hospitals. These are rooms where you would put an individual who has a very contagious, especially respiratory infection. You put them there in order to reduce the transmission via the air systems or the ducts to other parts of the hospital. In areas affected by MERS, they've also really ramped up the training of healthcare providers so that they can better identify coronavirus infections, and so that they know how to protect themselves. In the US, we typically have some pretty good systems in place. We emphasize masks and PPE, gloves, and that kind of thing to reduce the risk of healthcare providers picking up pathogens from the patients and then transmitting it to other patients. And, throughout the Middle East, we've seen, on the one hand, in the Gulf, you've seen some real remarkable improvement, but then in other areas, Northern Sudan, parts of Egypt, we don't know what's really going on in some of the areas affected with conflict. We've seen that we have major deficits in this regards. We also have some key populations that are extremely vulnerable to infectious diseases, particularly these respiratory diseases like SARS-CoV-2 or COVID-19. You've seen reports of migrant workers who ended up having very high rates of infection, especially throughout the Gulf. And some of the worker camps were quarantined from everyone else. You had mass movement of migrant workers back to their home countries, and oftentimes their home countries, really weren't able to implement a quarantine system once the workers returned. A lot of these countries were already having a very difficult time maintaining the basics of a healthcare infrastructure. And so, that has been a really critical global health challenge that has inadvertently highlighted some of the unfortunate realities of migrant labor. Migrant workers, individuals who live in refugee camps, internally displaced populations, they're also facing really high levels of stress on a good day. And we know from our work since the 80s that individuals who have high levels of stress are more likely to develop severe infection from respiratory illnesses, including some of the common cold coronaviruses. And these populations in the Middle East, really do need more long-term public health infrastructure and healthcare systems set up in order to protect them from this and from future outbreaks. Globally, we are seeing this rise in nationalism in many countries, not just in the Middle East. And this is a real problem for global institutions like the World Health Organization that are really premised on having good working relationships between countries. Through the World Health Organization, we are supposed to strive to really meet a basic level of healthcare and well-being for all across the globe. The World Health Organization and the UN have, several initiatives like the Global Health Security Agenda and the International Health Regulations that are really trying to promote reporting of public health emergencies of international concern or specific infectious disease outbreaks, and also other kinds of health crises in order to protect the global food supply, the global population. And when you're seeing this surge in nationalism and neighbors not being willing to share data, that's really problematic for global health and for regional health. So right now there are quite a few initiatives in place to really promote reporting of countries in the Middle East to each other. And this is really critical because we all know that borders are somewhat porous. I mean, right now, in lots of countries, especially those in the Gulf, they have greater resources. They're able to really monitor some parts of the border in order to reduce the risk of infected individuals coming through. But what is better is to have a good collaborative relationship between countries, and at a global level, it's really important. So these are some things that we really have to think through as we're trying to build up our global response and capacity for the next SARS-CoV-2, because unfortunately all indications are that these are not going to be rare 100-year or even 50-year events, but they are increasing in nature, or in frequency rather. And so, I will end the overview there, and then I'll just highlight a couple of cases that we have seen in the region. One of the better cases has been, Jordan's response to COVID-19. Part of it is it's a smaller country, and it is relatively better off economically than some of the other countries in the region. You know, they've really been able to do very good contact tracing and to track the virus, you know, and patients very closely. It's a mixed bag, right? On the one hand, you want this kind of system in order to control the spread of infectious diseases. You know, you want to be able to do some of what Jordan did, which is, you know, have the military ready to distribute food and things like that to neighborhoods that had to stay quarantined. But, you know, on the other hand, throughout the world, but really in the Middle East, you've also seen individuals who, you know, spread the virus either through not reporting that they had symptoms. You've seen them jailed. And, you know, there's lots of issues around, you know, these sort of human rights issues that do also need to be highlighted at some point. You've seen in Syria, Yemen, Sudan, many other parts of the Middle East that you've had very low reports of confirmed cases. And this, you know, it's really a symptom of having a broken surveillance system and very limited testing. And this is also another issue that I think many people are working to try to highlight. You know, just because the communication is that you have a handful of cases, it doesn't mean that's the reality. These reports are really based on a lot of other things, and the surveillance and testing piece is a critical part of that.
Wonderful. Thank you so much, Amira, for some fantastic discussion and presentations. I certainly learned a lot. I hope our audience did. And I want to make sure that folks we'll have this recorded and hopefully available on our YouTube page before too long. And please stay tuned to our email and social media accounts for announcements about further events. So again, once again, thank you very much. And it was great to see you.